Okay, good day everyone around the world. We're gonna start our seminar. My name is Jorge G. Ruiz, and I am a geriatrician, investigator, and associate director for clinical innovation at the Miami VA Medical Center, GRECC, and University of Miami in the US. On behalf of the organizing committee and the Global Frailty Network, we welcome all of you to our Frailty seminar series. On this International Women's Day, I want to take a moment to celebrate women around the world, but especially our colleagues in the fields of frailty, geriatrics, aging, and longevity research and clinical work, and education, certainly. Today, we recognize the social, economic, cultural, political, professional, and scientific achievements of women. It's only fitting that today we have a representative of females, an excellent representation of what we're talking about. Before I introduce our speaker, first I want to remind you about some housekeeping issues. Remind you to use the Q&A feature that is in the lower part of your Zoom to ask questions, and you can start as soon as you want. Try to avoid the chat feature unless you want to convey some message to the organizers or to your colleagues. Again, I remind you about the importance of the evaluations at the end of the webinar. You will receive an email with a link to the survey. We use the information from this survey to improve the quality and content of our seminar series. I also want to remind you about the purpose of the Global Frailty Network, that is to exchange and share evidence-based practices and research advances about all aspects of frailty. And we're open to involve healthcare professionals in geriatric medicine and other specialties interested in frailty, researchers, policy experts, trainees, and organizations. I also want to remind you about the upcoming International Conference on Frailty and Sarcopenia Research, ICFSR 2023, that will take place in Toulouse, France, this coming March 22nd and 24th. I hope you can join either face-to-face or virtually. Remind you that members of the Global Frailty Network and the Frailty Seminar Series will be there to interview the 6 keynote speakers, and will be disseminating these interviews by Facebook Live. And now, I'm going to introduce our speaker. It's my privilege to introduce today's speaker, my friend and colleague, Dr. Olga Theou, who is a member of the Frailty Seminar Series Organizing Committee and Steering Committee of the Global Frailty Network. Dr. Theou is the Canada Research Chair in Physical Activity, Mobility, and Healthy Aging. She's an assistant professor of physiotherapy and geriatric medicine at Dalhousie University, Canada. She's also an affiliated scientist of geriatric medicine with the Nova Scotia Health and adjunct senior lecturer of medicine with the University of Adelaide in Australia. She obtained her Bachelor of Science in Physical Education and Sports Science at Aristotle University in Greece, Master of Science in Gerokinesiology from the California State University in Fullerton, and PhD in Health and Rehabilitation Sciences with a specialization in health and aging from Western University. In 2013, she was awarded a Banting Fellowship, which recognizes exceptional individuals deemed likely to contribute positively to Canada's economic, social, and research-based growth. Her recent interests include aging, frailty, and physical activity, and she has been ranked 5th worldwide in frailty expertise by ExpertScape. She's become one of the most recognized leaders in the field of frailty research, especially in the development and evaluation of frailty assessments. And today, she will share a lot of that work when she talks about new developments in frailty index assessment. So welcome, Olga.
Thank you so much, Dr. Ruiz, for your kind introduction. It's a great honor to be here, and I'll try to do justice to your introduction. I'll share my screen. So the title of my presentation today is New Developments in Frailty Index Assessments. I'll try to present approximately 40 to 45 minutes, so leave enough time at the end for questions. And please add your questions to the Q&A tab as we go along. So for the presentation today, I will start with a little bit of introduction around the Frailty Index. I know that this is a concept that may be familiar to many of you, but just to make sure that we're all on the same page, I will do a little bit introduction to the concept. Then I will talk a little bit about some recent work we've done around how frailty indices can be constructed. and also some of the newer tools we developed based on the deficit accumulation approach. And I will finish my presentation on talking about how the frailty index can be used as an outcome measure in interventions, and specifically on physical activity interventions. Just to disclose, the frailty index is one of the tools available out there. There are more tools. Also, the deficit accumulation approach, which is the theory behind it, it's not the only approach that exists for frailty. And today, for my presentation, I'll focus more on our recent work because I thought it would be more relevant to the audience, work we've done in the last 3-4 years. Of course, there's more work done by a group that I might not present today. And of course, there's more work that done by other groups around the world on the frailty index that I will not focus on my presentation today, but I'm happy to discuss at the end during the discussion time. So I will start first with a little bit of introduction around the concept of the frailty index. This is the first paper that the frailty index was published on in 2001 by Arnold Mititsky, Ken Rockwood, and colleagues. This was the first paper also introducing the deficit accumulation approach, and it was the outcome of several years of work before this publication came out. And I would say the first decade was a little slow, not just on the frailty index, but I would say generally on the frailty literature. But things picked up around 2010 with an exponential increase on the number of papers published on the frailty index and generally on frailty, I'll say again. This is basically number of publications in PubMed using the keyword frailty index. I was lucky enough to join the frailty index group, Dr. Rockwood's group, in 2011, and being at the time when we start seeing this increase in generally on frailty research and specifically also on the frailty index. And nowadays we see 600 to 700 publications every year published on the frailty index. So there's definitely an increase in the literature. Just a brief overview about what is frailty based on the deficit accumulation approach. Frailty is considered a state caused by cumulative decline across multiple physiological systems. Because of this decline, people are vulnerable and at risk for adverse outcomes, especially when we compare people of the same chronological age. So we might have two 70-year-olds. The person who is frailer are more likely to experience adverse outcomes. These frailer people are also vulnerable to various stressors, physiological, psychological, environmental stressors. For example, we have two people same age having a COVID-19 infection. The frailer person are more likely to be hospitalized, admitted to ICU, being ventilated, die sooner. But also we can think about stressors such as a heat wave. When there's a heat wave, the frailer people are more likely to experience outcomes that will never be experienced by fit people, even if the same age. Most important, we need to consider frailty as a continuum with extreme fitness on one side and severe frailty on the other side. And pretty much every adult is along that continuum. There might be change over time. And the most important is that frailty is reversible. People can reduce their frailty levels. People can improve their health. Frailty doesn't start at the age of 65. Frailty doesn't start at the age of 50. It starts at a much younger age. We can say around the age of 18 when most of our organs start experiencing decline with aging. So if we really want to capture frailty, we need to start earlier, not wait until old age. And even though most of the literature on frailty and the frailty index is focusing on people over the age of 65, there are publications, including people as young as 60-year-olds. Here's an example of how two people, the same person at the age of 55 and the age of 65, and how they accumulated damage over their life. So pretend every circle is the human body. Every node represents a different part of their body. When it's white node, it means there's no damage. When there's a blue node, it means there's some damage accumulated. So this person at the age of 55, they had some damage accumulated. For example, abnormal sodium levels, abnormal glucose levels, a little bit of mobility impairment, but generally they were doing very good. Fast forward 10 years later, when this person is now 65 years old, they have accumulated further damage. For example, they have some new cognitive impairments, which made them frailer and more at risk for adverse outcomes compared to how they were 10 years earlier. So based on the frailty index, frailty is a risk state. It is based on the deficit accumulation approach. Important distinctions with other theories is that it's focusing more in the quantity rather than the nature of the health problems. So based on this tool, we care more about how many problems people have, less on what type of problems people have. The variables included in the frailty index are not pre-specified. You might have 2 frailty indices developed that they can look quite different. They have different number of items, different type of items. But if they're constructed properly with following the right procedures and criteria, they could have comparable results. We suggest that at least 30 items included in the frailty index. And most of the frailty indices developed have less than 100 items. However, we've seen recent publications having more than 100 items too. And in order to calculate the frailty index score, we need to divide the number of deficits an individual is experiencing by the number of items that have been considered. For example, if our frailty index has 100 items, someone has 20 problems, the frailty index score would be 20 divided by 100.2. And the score ranges from 0 to 1. The higher the score, the frailer this individual will be. This is an example from a frailty index that we created in a Canadian longitudinal study on aging, including 52 items, such as chronic conditions, basic and instrumental activities of daily living, questions related to health, vision, and hearing, and also cognitive impairment and mental health questions. And I would say that this is a typical frailty index. Includes more than 30 items, includes multiple domains, and typical domains included in a frailty index. And using this data from the Canadian population, we see how frailty increases over time. It starts at 45 because that's the population that was included in this data set. But as I mentioned before, frailty starts earlier. So if we had people younger than 45, we would also see some levels of frailty. And we see an increase with age. And let's see, having 2 people of the same age, hypothetical person X and person Y, both 65 years old. Person X has a frailty index level approximately 0.04, which is the average frailty index score for someone at the age of 45. And we have person Y, who is having a frailty index score around 0.13, which is the average frailty score for a person at the age of 85. So even though these people have the same age, person X is more experiencing more slow aging, versus person Y might be experiencing a more accelerated aging. Person X might look biologically more like a 45-year-old. Person Y might look more like biologically an 85-year-old. And for this reason, it has been suggested how frailty can be used as a marker of biological aging. Some of the advantages of the frailty index. The frailty index can be applied retrospectively in almost any health data set, as long as the right items are included in the data set and the procedures are followed. It is considered a comprehensive assessment of health, especially when several domains of health have been included in the measurement. It provides a continuous score from fitness to frailty. And this is many times preferable, not only for research, but also for clinical practice. So we can not only see who is frail or non-frail, but also we can see different levels of frailty. As we know, people who have mild levels of frailty, they look quite different from people who have severe levels of frailty. So grouping them into one category might not be as beneficial. So we want to separate these categories. It is sensitive to health change. If someone's health change over time, as measuring frailty with the frailty index will be able to show the difference in the frailty index score. Also, it doesn't have a ceiling or floor effect. Rarely people have a frailty index score of 0. It happens even in big studies, but it's a very small proportion of the population. And almost never anybody has a score of 1. Just to also emphasize the disadvantage that many people, let me go back. One of the disadvantages that many people identify for the frailty index is that it needs at least 30 items to be included. This could be a burden if people need to collect new data, but many times the frailty index is constructed retrospectively using data already collected, either in research or clinical practice. But then it's not as a big burden because more than 30 items typically is available in this type of data sets. Some of the characteristics of the frailty index. It can predict adverse outcomes, including mortality, disability, healthcare utilization, and especially in clinical settings, we can see the frailty outperforms chronological age as a better predictor of outcomes. Many times when we put them in the same model, age might not be even a significant predictor. In community dwelling people, we see that the distribution is left skewed, meaning that majority of the people would be healthy and low frailty index scores. In clinical samples, especially within geriatric medicine, we might see more like a normal distribution. As mentioned earlier, it rarely doesn't happen. Someone to have a frailty index score of 1. Typically, people don't exceed the limit of 0.7 as of a frailty index score. And that's usually is because people cannot tolerate more health problems than after that level. So for example, if a frailty index score has 100 items, people cannot have more than 70 health problems. If they get more than 70, potentially they won't be able to survive. We know that the frailty index scores increase with age, but can also decrease, showing that health can improve over time. With community dwelling samples especially, and when frailty index includes self-report items, we know that females are frailer than males, but we also know that females have better survival than males, which has been considered as a paradox in the literature. But I'll discuss a little bit later that might not be true for frailty indices, including other type of items. We've done some work trying to understand the prevalence of frailty. And this is again Canadian data. And we look specifically for a number of people who have at least a very mild levels of frailty. So the earliest possible stages of frailty. We found that among middle-aged people, 34% of females, 28% of males have at least a very mild level of frailty. Numbers are a little higher for the older adults, 58% of females, 47% of males, suggesting that at least 1 out of 2 older adults may have at least a very mild level of frailty. However, we don't, as I mentioned earlier, we don't just want to dichotomize frailty to frail and non-frail. We want to look at different levels of frailty. Here we grouped, again, with the Canadian data, we grouped people using 0.1 groupings of frailty, green representing a level of less than 0.1, yellow 0.1 to 0.2, orange 0.2 to 0.3, red 0.3 and above, typically where we see moderate frailty levels starting. The numbers for moderate frailty levels are not as high, but this is, again, it's a population study, and we know that severe frail people and even moderate frail people typically not be included in the studies. So it's not that they don't exist out there, it's just that they typically are excluded from population studies. And on the y-axis, we have different age groups. So you can see, for example, at the age of 45, I'm sorry, the font might be a little small for you. At the age of 45, more than 80% of the population is non-frail, and we have a very small number of people being 0.2 and above frailty index have like a higher levels of frailty. As people are getting older, they are much more frailer. So at the age of 85, less than 20% of the population would be non-frail, the frailty index score less than 0.1. And that's when we see higher number of people with moderate levels of frailty, with 10% having a frailty index score 0.3 and above. Showing here the value of looking at different levels of frailty across different age groups. Was also involved with some work that we did led by the Canadian Institute for Health Information. And the publication from this work is actually coming out soon. The Canadian Medical Association Journal, it was recently accepted, that used classified frailty, looking at administrative health data for all hospitalized Canadians using ICD codes. That's not the first time ICD codes are used to calculate the frailty index score. And also generally even with routine collected data. We know that many of you be familiar with the work done from NHS in UK, where every patient in primary care can have a frailty index score automatically calculated based on the electronic medical records. So that's when we start seeing more administrative health data sets being used and clinical data sets being used for constructing frailty indices and identifying frailty levels. So based on this work that was done with the Canadian hospitalized patients, we found that at least 1/3 of the population were frail for people admitted to the hospital. And people who were frail, they were 3 times more likely to be high users of hospital beds and be hospitalized for 30 or more days. They were twice more likely to be readmitted within 30 days after discharge and die within 1 year after discharge. Again, not dichotomizing only frailty, looking at different frailty levels. We found a skewed distribution, not as many people being very healthy, especially with a community in a hospital sample. But on the other side, we don't have as many very severe frail people. There were 36 items, ICD codes included here, combining ICD codes. So not many people have more than 16 out of 36 items, which would be considered a very severe level of frailty. Just mention some work we did that you might find it useful. It's life expectancy for people across different age groups, for females and males. As expected, females live longer, but the distribution of the different levels of life expectancy, it was similar for the two groups. So if we just focus on the 55-year-old females, we can see that it is expected for a 55-year-old to live approximately 17 years of life with no frailty, approximately 7 years with mild to moderate levels of frailty, and approximately 3 years with very severe frailty. As people are getting older, they're more likely to live with frailty and less likely to live with non-frailty. For example, a 90-year-old might only live 1 year with no frailty, a couple of years with mild, moderate frailty, and a couple of years with severe frailty. And of course, there's variability across people, but that's average scores, average life expectancy for different age groups. We were also very interesting to see how the frailty levels might change by different cohorts. This is using US data. And we looked at people, the cohort from 1999, 2000, up to the cohort from 2017, 18. This is people over the age of 20. Results are not drastically different, but there is a clear trend that our population is getting frailer. So we have less people with a frailty index score less than 0.1, which we'll consider them non-frail people, and more people with higher levels of frailty, and a significant increase in the number of people with a frailty index score greater than 0.4. So it's clear that our population is getting frailer. The only difference we saw is on younger women. We got a trend a little bit that potentially younger women are becoming less frail over the last 15 to 20 years, but you feel free to check the paper. We'll explain a little bit more this difference. But for the rest of the groups, and for both males and females, it was clear that people are getting frailer. So to move on to the second part of my presentation, talking a little bit about how a frailty index can be constructed, or some of the new work we did around the construction of a frailty index. In 2008, one of the first papers were published around some standard procedures for creating a frailty index. And this paper has been widely cited and widely used in research and clinical practice. But recently we did updated these guidelines to try to suggest some easier ways about how to construct the frailty index using existing data. So we created 10 steps. This is unpublished work, but it will be submitted very soon. Suggesting as the first step, when you have already an existing health data set that you're interested to create a frailty index, is first select variables that measure a health problem, then exclude variables with more than 5% missing values. This is not a magic number. It can be around 5%. The main thing is the more variables you include with a lot of missing data, the more likely in the end is you have to exclude people when you try to calculate the frailty index score. So the more conservative you're at the beginning of the process, the more people will be included in the end stage of the process. All items included have to be coded between 0 and 1. We exclude variables that are too rare or too common. Most important step is screen the variables included for association with AIDS. We're looking for items that are possibly associated with AIDS. And we also look for variables that are not too highly correlated with each other. We don't want items that basically measure twice the same thing. We need to count how many variables being retained after you construct a frailty index. As I mentioned before, we're looking at least for 30 items, but generally speaking, the more items included, the better the frailty is, the more reliable and the more accurate. Then we calculate the frailty index score for people who have at least 20% of the items, less than 20% of missing items. We try to test the characteristics of the frailty index before using it for analysis. typical things we looked at characteristics of the frailty index is association with age, sex differences and distribution, and if we have outcomes, association with outcomes. And then we use the frailty indexing analysis for whatever research question we might have. We suggest to use the continuous score as much as possible for research and clinical practice to identify different levels of frailty, but we understand sometimes categories need to be used and they have their own purpose too. We suggest to try not to dichotomize frailty, try to include as many frailty levels as possible to understand who is mild, moderate, severe, and very severe frail. Initially, the frailty index was constructed mostly with self-reported items. It initially started from population studies, which typically that's the type of items they're including. And sometimes the frailty index will include 80%, 90% of the time self-reported items. Some blood tests or vitals or physical tests will be included. But over time, things start changing, and then we start seeing frailty indices being constructed only using laboratory tests. This is a meta-analysis that was recently published, identifying 38 studies that used frailty indexes constructed only from laboratory tests. That was published between 2010 and 2022. And they showed high to moderate quality of evidence around the relationship of the frailty index with outcomes. They identified that for every 0.01 change in the VFI lab score, there was a 4% increase in mortality. And you might think that the 4% increase is not as big, but the change in the VFI lab score is quite small. It's only a 0.01 change. So it's a matter of units. If you use a higher unit, if you use a 0.1 increase in the VFI lab score, the hazard ratio would be, of course, higher. So the 0.01, it is one that is typically used, but understanding that this is going to end up with a smaller odds ratio or hazard ratio. Also, the meta-analysis showed that the VFI lab was associated with several outcomes in most of the studies. Earlier, I mentioned about the sex differences that in frailty indices constructed mainly with self-reported items, it's typically seen that females have higher frailty index score levels. Things is not as clear when using laboratory FIs. And that's why the evidence it was very low. Some studies showed that males were frailer, other studies showed females frailer. The other studies showed that it's not relation with sex between the VFI lab scores and sex. So results are not as consistent as when you start using more biomarkers for the construction of the frailty index. We took it a step further with Canadian data, and we created 3 frailty indices just to see how they behave and examine their characteristics and also their association with mortality. We created a 48 item frailty index, including self-reported items. As I mentioned before, chronic conditions, activities of daily living, mental health, self-rated health. We included the frailty index with 23 items, including only blood tests, and a 47-item frailty index based on exam-based tests, such as physical performance tests, cognition, anthropometric measures, respiratory measures, hearing and vision, and cardiac measures. We found there were some characteristic differences as expected based on the type of items included in the frailty index, but also looking at the relationship of the 3 frailty indices with mortality, we found that all of them were predictive. Not surprisingly, they were predictive of mortality with an area under the curve closer to 0.8 for all of them. But where we saw the strongest prediction was either when all 3 frailty indices were included in our prediction models, or when all the items were included in a frailty index combined. So because of this, we suggested that in order to capture frailty better, in order to understand better the heterogeneity of aging, we should consider including several types of deficits in our frailty indices. So we should target for as many items as we can to have a more reliable frailty index, but also we should target to include several types of items if available. So we shouldn't just use self-report, but we should also try to use blood biomarkers, but also different performance tests too, if they're available. To move to the next part of the presentation is around some of the new frailty tools that have been developed following the deficit accumulation approach as a theory. Many of you might be familiar with the clinical frailty scale, which is one of the most widely used scales within clinical settings. It was initially published in 2005, initially with 7 levels, then expanded later to 9 levels. And in 2020, we did a small revision of the scale, having now version 2.0, the one publicly available. And mostly what we did is changing the wording of the different levels and focusing a little bit better on the scoring of the frailty in people with dementia. But the content of the clinical frailty scale remains similar. The idea is that it's a clinical judgment-based tool. Initially, it was used to summarize a comprehensive geriatric assessment. Nowadays, especially since COVID, it's been used a lot as a screening tool to understand quickly the risk of frailty of a person. So the nature of how the scale is used has changed. It still requires clinical judgment, though, to identify where we think our patients or our participants belong to, which category from the 9 belong to. So the idea is that you do an assessment, and then based on the assessment you did, you try to identify where they fit best, for which category they fit best. There are some icons there to represent levels, but it's more important the description. It's not just the mobility scale. The description of every level is what really is the important part of the scale. During COVID, we saw the clinical frailty scale used a lot as a screening tool outside geriatric medicine. And we knew many people had hard time applying the clinical frailty scale in their patients. So to assist them, we developed this classification tree tool, which is not supposed to replace the clinical frailty scale. It's supposed to assist with the scoring of the clinical frailty scale. So the idea is that someone that used the classification tree, get a proposed score based on the tree, they need to confirm whether they agree or not with the score, and they're free to change the score based on their clinical judgment. So it includes some questions, but it doesn't take too long. First question is around how terminal ill people are. If people are terminally ill or not. Then it's how many basic activities of daily living and instrumental activities of daily living people may require help. Then we can ask questions around chronic conditions and self-rated health for people, a question about mental health, and then whether people exercise or not. So by applying these questions in different settings, we can get different proposed scores for our participants, proposed scores for the clinical frailty scale score. But as I mentioned again, it still requires the last step to be to confirm whether the assessor agrees or not with the score. We did a validation work within our hospital when we developed the classification tree, and we found a pretty good agreement between the classification tree and the clinical frailty score as traditionally done by geriatricians and GRECC residents. And what we found when we compared the classification tree and the geriatrician clinical frailty scale score is that in more than 70% of the cases, the score was the same. However, in some cases, the score would be less by 1 level or more than 1 level. So we expect that if someone uses a classification tree, in most cases, the score that was being suggested by the classification tree will be the correct score. But sometimes, not most of the times, but less than 30% of the time, they might have to either score a little bit higher, 1 level higher, or 1 level lower. The other tool that I would like to suggest that was recently published by our group is the Pictorial Fit Frail scale. That scale was used primarily, it was only assessed for the assessment, only images are used. It was what started the development of this tool is we're trying to find something in the middle between using the clinical frailty scale as a screening tool and doing comprehensive geriatric assessments. So this was in the middle. See, people who don't want us to do a very quick screening, but people who want to do a little bit more comprehensive than that. So this scale uses only images. It has 14 domains. Domains like mood, mobility, balance, tiredness, memory, hearing, and aggression. Every domain has different levels representing a worsening ability. And there are up to 3 to 6 levels for every domain. People can self-assess themselves using the scale, or it can be used by caregivers or healthcare professionals. And based on where they see they fit in every domain. So based on the pictures and the images, where do they think they might belong to, and what picture might represent better their function of that domain. The final score can range from 0 to 43, with a higher score representing worse frailty. And because it uses only visual images, it is accessible across literacy levels, languages, and cultures. And work has been done from people across the world using now the scale, and we have already requests for translating the scale in different languages. And the translation is a little easier with the scale because it's mostly images, so it's more the instructions and the domain names that need to be translated. It's quite feasible, considering that a clinician can do the assessment in less than 2 minutes. A caregiver or patient might take slightly longer, but still it might be less than 5 minutes, the assessment. We saw in our validation work a good test reliability for patients and healthcare professionals. Validation work, similar reliability work done by other groups with bigger samples, actually showing the numbers are much higher. And we also saw good inter-rater reliability between healthcare professionals. Work done by us and others showing that the scale is valid. It has been associated with other commonly used and validated frailty tools, but also has predictive validity, the ability of the pictorial scale to assess the outcome, various adverse outcomes. And I know there's work currently done also to evaluate this using the pictorial fit for scale as an outcome measure in clinical practice. And to move to the last part of my presentation, I will talk how the frailty index can be used as an outcome measure in interventions, specifically on physical activity interventions. And there's a lot of discussion around how you can use a tool as a main outcome measure within clinical trials, especially, and the importance of have some type of clinical meaningful change cut point for a tool. So we did some work to validate what would be a clinical meaningful change in the frailty index. We used data from hospitalized older patients who were admitted to hospital across Canada for respiratory illness. We constructed a 39-item frailty index, but also a clinical frailty scale score was available, assessed by clinicians at pre-admission, admission, and post-discharge. And we suggested as the reference standard for us would be change in the clinical frailty scale score. If a clinician have identified someone to change the CFS level, it is a clinical meaningful change. So we're trying to find what frailty index score would predict this change in the CFS. And we found that for the frailty index, that would be around 0.03 change in the frailty index score. So that could be suggested as a clinical meaningful change score for the frailty index. And there's work done by other groups too, that they also propose similar cut points for clinical meaningful change scores for the frailty index. And I mentioned that I will focus a little bit more about the physical activity interventions. One of the main reasons is we know that physical activity has been shown to be quite beneficial for people across levels of frailty, especially older adults. And we did some work here, an observational study using US data, trying to see how active people are across levels of frailty. Generally speaking, people were inactive, but people were even more inactive when they were severe frail and moderate frail. So for example, at the stage of non-frailty, people spend 50% of their time in prolonged sedentary time bouts of more than 30 minutes. So sitting down for 30 minutes or more. 42% of their time in sedentary time, but lasted less than 30 minutes. And the 30 minutes bouts has been suggested as a good cut point for bouts of sedentary time that can be quite harmful. 39% of their time in light physical activity, and 2% of the time in physical activity with a moderate or vigorous intensity level. As people were getting frailer, they become more inactive. So for example, severe frail people spend almost a quarter of their day in sedentary bouts of more than 30 minutes, almost half of their day in sedentary bouts of less than 30 minutes, only 29% of the day in light physical activities, and less than 1% of the time in moderate vigorous physical activity. So severe frail people are quite inactive, spending almost 75% of their time in sedentary time. So we're interested to see how people engaging in physical activity, whether that would reduce their frailty level, whether that would prevent frailty. We did recently a study, secondary analysis of a randomized clinical trial, might be familiar to many of you, the LIFE study. which included more than 1,500 people between the ages of 70 and 89 years old, were at risk for mobility disability. There was a control group that did health education. There was a physical activity group that participated in 2 group-based exercise sessions per week. The main outcome for the trial was major mobility disability and death up to 3.5 years. For the purpose of our secondary analysis, we constructed a 44-item frailty index and were able to identify frailty level of our participants at half year, 1 year, 1.5 years, and 2 years from baseline when they were recruited to the study. And using the cut point proposed earlier, we were looking for clinically meaningful change of more than 0.03 in the study. Surprisingly, we didn't find a difference between the 2 groups. We did find that over the 2 years of the study, people became frailer, but we didn't find a significant difference between the control group and the intervention group. When we looked at the clinical meaningful change, we could see a slight trend with the exercise being a little better, the exercise group doing a little better, but that was not statistical significance. So at 6 months, for example, almost 23% of the exercise group got better, approximately 30% of the group remained stable, and then around 30% of the group got worse. As time passed, closer to the 2-year time point, we saw less people improving and more people worsening and dying, and we didn't see a major change between the control and exercise group. What we did in this work, and in several of the studies also later, is trying to see whether the baseline frailty level of the people would be important about what the impact of the intervention, whether the intervention would be more effective for people with higher levels of frailty or low levels of frailty. So for our analysis, we centered our frailty score in different levels from 0.05 to 0.45. What we found is that the impact of the intervention on disability and mortality was not significant for people with a frailty index score of 0.1 and below, which is we consider non-frail people. However, the effect of the intervention was getting bigger as people are frailer, which is a little contradicts what many people believe, that people are too old or too frail to participate in exercise programs. Here we show that actually the frailer someone was, the more benefit they got from the intervention. And actually we show that the intervention might not be, the specific intervention might not have been as useful for people with very low levels of frailty, which shows how potentially we need to modify their interventions, physical activity interventions, but potentially other type of interventions based on the frailty level. And might not be one size fits all, and one intervention for every level of frailty. We also did some secondary analysis from data we had from a cardiac rehabilitation program here in Nova Scotia, which included more than 2,500 people with cardiovascular disease who was referred to cardiac rehabilitation, a standard rehabilitation program that was supervised program for 12 weeks, including exercise and education twice per week. We created a 25-item frailty index to see who participated, what the levels of frailty of the people who participate in the program, but also what the levels of the people after they were discharged from the program. We saw quite a big variability among the frailty levels of the people at admission. We had 16.8% of the population have a frailty score of 0.2, non-frail people or very mild levels of frailty. 27.1% had a level of 0.2, 0.3, which we can call as mild levels of frailty. Almost 30% a level of 0.3, 0.4, moderate levels of frailty. 18.5% consider severe frailty, severe frail people, 0.4, 0.5 frailty index score. And even we saw 7.8% of the population had a score of 0.5 and above, which is severe, very severe frail levels of frailty. So there was quite a variability on the people who participate in the cardiac rehabilitation program. The good news is that on average, there was a decline, significant decline in the frailty levels of the participants from admission to discharge after the end of the 12-week program. There was a reduction on average of 0.07 in frailty index, which is above the clinical meaningful change that we observed in the studies. And that was around 2 deficits. So people lost 2 health problems by participating in this cardiac rehabilitation program. When we looked at different changes of frailty, using the cut point for the clinical meaningful change of 0.03, we saw that 68.7% of the people actually had an improvement above the clinical meaningful change, which is a quite significant number of people. We wanted also to see there's the people who increased above that cut point, because there are different levels of change above the clinical meaningful change. And even when we looked at the large change, more than 0.11 change in the frailty index, we still had more than 1/3 of the population improve above that clinical meaningful, above this cut point, showing that cardiac rehabilitation could be quite beneficial for the people who participate. When we looked whether the baseline level of the people could affect the improvement people experienced during cardiac rehabilitation, we saw similar results with a previous study that I showed earlier, that the frailer the people, the more beneficial the intervention was. So people with very low levels of frailty or non-frailty, less than 0.2 frailty index, they still had an average decline of 0.03 in the frailty index, but things were way better as people becoming frailer. So for very severe frail people with a frailty index score of greater than 0.5, experienced a reduction on average of 0.12 change in frailty index score, which is a little bit more than 3 deficits decline. Again, showing that cardiac rehabilitation might be more beneficial even for people who are frailer. We shouldn't be afraid to refer people with high levels of frailty in programs like that or other type of exercise programs. And what do you think? And so again, showing the impact of the baseline frailty level for these people. And from previous work we did with this population, we also saw it, unfortunately though, that these severe frail people are less likely to participate in cardiac rehabilitation program and less likely to complete the cardiac rehabilitation program. So even though they might be the ones that get the most benefit from the program, they are less likely to participate. So that shows how we need to start modifying our clinical programs to target better the frailer people and to attract them and make sure that they complete the program. And the last trial I will explain that we did secondary analysis on is a trial from Spain, including 370 hospitalized older adults over the age of 75 who were admitted in a geriatric ward. There was a control group and there was an exercise group that did exercise, including moderate intensity, resistance, balance, and walking exercise twice daily while people were in the hospital for 20 minutes, including weekends. We created a 63-item frailty index score to see the impact of the intervention on frailty. And we saw drastic differences between the two groups. In the intervention group, almost 70% of the intervention group improved the frailty index. Approximately 25 to 30% of the group remained stable. Stability means a change that it was less than 0.03. And less than 5% of the population that participated in the intervention group actually got worse for admission to discharge to the hospital. Whereas the control, the results were quite different, and of course, statistically significant too. Almost 20% of the population from the control group improved their frailty index score. Close to 50% remained stable, and 30% of the population actually got worse. So showing how extremely beneficial was the participation of the exercise program during hospitalization for these older people in this geriatric ward. We're also interested to see the impact of the intervention based on different frailty levels at baseline. I will focus here more on the intervention group. You can see here how for people who have very low levels of frailty or they're considered non-frail, around 50% of the population got better. As people now are frailer, like more to the mild, moderate levels of frailty, we saw that 60% of the population and above 60% and above got better. Whereas for the people who were the frailer, we saw that almost 90% of the population got better, showing again that the frailer the people were at baseline, the more benefit they got for participating in the intervention. So we need to make sure that these people have the opportunity to participate in these programs and don't get excluded by these programs, which is quite common, not only in research, but also sometimes in clinical programs too. And sometimes how we need to modify programs that will fit different levels of frailty. And what we might find is that programs that designed might not be as challenging for people who are quite healthy, and how we need to make them more challenging for the less frail people to get benefit also from these programs. So to summarize for my presentation, the Frailty Index, I introduced the Frailty Index and showed how it's one of the leading paradigms for understanding frailty. The Frailty Index has been used in research and clinical care around the world. Recommending always to include as many items as possible and as available for the frailty indices, but also including multiple type of items, multiple domains, make the Frailty Index stronger, more accurate, better predictor of outcomes. I introduced some new frailty tools that we developed, specifically the clinical frailty scale classification tree and the pictorial fit-fail scale that could be fit for different studies or for clinical practice. And I also end up discussing a little bit about the Frailty Index as a useful outcome measure when examining the impact of intervention. And specifically, I gave some examples from physical activity interventions that we did recently. And also just to acknowledge that you find a lot of information, especially for the new tools we developed in our website, gmru.ca, where you can find more information about the tool and how it can be used in research and clinical practice. Before I finish, I would like to acknowledge our trainees and collaborators. This is everything I present today. It is recent work we've done in the last 3-4 years, but definitely it's an outcome of several people working in our group. Our trainees, our collaborators, especially Dr. Rockwood, and of course our founders, who without them we wouldn't be able to complete many of these projects. Thank you so much.
Thank you, Olga. Great presentation, and I think we have a lot of excitement in the audience and several questions. And what I'm gonna put in the chat the link to our Twitter page, so you can continue asking the questions if we don't have time to deal with them. Dr. Theou has agreed to that, and I'll send you that so you can send your questions there, and she may try to answer it after the conference. So let me start with some of the questions here, and I'm going to try to combine some of them because they are related. And one of them is, does the index take into account the severity of the included condition, early COPD versus end-stage COPD or continuous oxygen? And similar to that, Olga, I think it's very similar, is the other question by, I think, Amani Ali, is that the level of frailty is correlated with the number of deficits, we know that, but could be the proportion of organ damage. I guess it's another way of framing severity. So I think those two questions are related. Go ahead.
Yeah, you can definitely take into consideration. For example, if you want to include COPD as one of the items, and you have, because you code it between 0 and 1, you can code 0, someone who has no COPD, 0.5, someone who has early stage of COPD, 1 is someone who has severe stage of COPD. So you can take consideration the severity of any condition or any items. So it can be done within an item, including the frailty index, could be also added with multiple items included in the frailty index. For example, falls, someone could be a question, did you experience any falls? And the second question could be included as a separate item, did you experience multiple falls? So there are different ways to do it, and the more information you put in, the better the frailty index would be.
Okay.
Generally speaking.
Thank you. There are other questions that I think they are related, and I may omit some of them. Can you mention how often the prevalence of or incidence of those people improve? I guess it's the changes in the frailty score that you alluded to before, whether their health improve spontaneously or probably as a result of interventions.
Yeah, I mean, it depends on in a population study, there's a significant number of people improve. I mean, I can, off the top of my head, I can bring a number that will be applicable across every study that's done. But I would say a significant number of people improve. And I know many times we're obsessed with the average scores, and we keep saying how people on average, they get worse as they're getting older. But we do have a significant number of people improve over many studies. Typically annual assessments done in the studies 1 or 2 years, and we do see many people improving. Of course, with interventions, we may see more people improving, but it's a group that we typically forget and get washed out when we do the analysis using average scores. But it's a very important group that we can explore and see how they improve. Of course, if assessments are shorter term, like if you see people, if you do assessments weekly or monthly, things might be a little different than if you do follow-up assessments annually.
Great. Another question for Dr. Guralnik. It appears from that the clinical frailty index relies almost exclusively on functional status as opposed to the traditional frailty index, which is heavily dependent on disease status. Is this true, and can you compare the two approaches?
They have a little different approach to the assessment. I mean, the frailty index is also they're heavily, the items are included, many of them are actually function related. So I wouldn't know if it's one more than the other. It depends on how you score the CFS, but both of these tools use function as a way to understand the frailty level of the person as indicators of the frailty level. So both of them do include function in their assessment. So, and it's important to be assessed as a very good marker of understanding people's health status.
Okay, another one is about dementia, I guess. And how does dementia affect the frailty assessment tools, specifically the frailty index? Does the index, I guess, lose fidelity in patients with dementia?
No, I wouldn't say so. I mean, the main problem you might have is that how the assessment will be done. If people have like end-stage dementia, how are you going to get information from this population? If you use routine data, or it has to be self-assessed. But that's why it depends what type of items you included. Ideally, you shouldn't do a frailty score only including dementia items. It should be multi-domain. You could include cognitive tests in your frailty score, but it could be used in the clinical frailty scale. It's typically we're mimicking the levels. So people who have mild dementia most of the times also have mild levels of frailty. People who have severe dementia, they also have severe levels of frailty.
A couple of questions, I guess, talk about whether the frailty index has been adapted to primary care in contrast to hospitalized patients. I think you answered that, but I don't know if you want to add anything about the frailty index in primary care settings, community settings.
Yeah, no, it has been done. It has been done. And there's different groups creating their own frailty indices for their own electronic medical records. I mentioned for NHS UK having a frailty score included in every record. In Canada, I would say, I think it's a year now old, that TELUS incorporated a comprehensive geriatric assessment within primary care, electronic medical records, which pops up and automatically an electronic frailty index score after you fill out the assessment. So it has been used. It's been used not only for research, but for clinical practice, either retrospectively or prospectively.
Another question is related to you mentioning the new guidelines for constructive frailty indexing, which you said that you'll eliminate variables that have a lot of missing data. I guess the question is, what is the cutoff for missing data? What is the proportion?
So, I mean, when we started population data sets, frailty index construction, where missingness is not such a big issue, we usually exclude variables that has more than 5% missing data at the variable screening stage. And then in the end stage, when you calculate frailty score for every participant, we only include people who have less than 20% missing data. Now, and that's create a balance in order for most people to have a frailty score at the end. For clinical data sets, we've been, and ourselves and other groups, we've been pushing a little bit these cut points to allow more missingness, because that's in clinical data sets, it's more common to have missing data. But what happens is the more missing data you allow, the more people you will have to exclude at the end when you calculate the score, which makes it less representative of your population. So it's a fine balance. It's a balance between which one is more important, having a smaller group with good enough valid information, or is it more important to have information for as many people as you want? There is some work done recently with using imputation methods, and there are some potential imputation methods that could be used to impute some of the missing data and create accurate scores for everybody.
Another question in terms of this longitudinal studies using the frailty index, how is death handled? Are the people who die excluded from the calculation, or are they assigned an arbitrary frailty index at death, such as 1, I guess?
So I'm assuming you mean when frailty index is used as an outcome measure, because baseline, it would be included for everybody. So what we've done in some of our studies is when we look at change, you can do it. We usually don't include. They would either be excluded or doing some competing risk analysis. It depends on the type of analysis you want to do. But when we look at outcomes using the change in score, for example, the clinical meaningful change, we might combine and say people who got worsened or died. We might combine them as one group, assuming it's a worse health state. So we might combine them with the worst frailty level when we use frailty as an outcome measure.
And there are still many more questions for Olga. And like I said, I'm gonna encourage you to send your questions to our Twitter handle, so then she will try to answer them. I will save them. But I just want to thank you for participating, and thank you, Olga, for a great presentation. I want to remind you about the next webinar panel. It's going to be Wednesday, April 12th, and it's going to be a panel on frailty and cognitive impairment. Dr. Ken Rodwood from Dalhousie University, Oliver Duchette from McGill, and Dr. Carlos Cano from Pontificia Universidad Javeriana in Colombia will be the panelists. And again, remind you about the importance of evaluation at the end of the webinar and the International Conference on Frailty and Sarcopenia Research on March 22 to 24th in Toulouse, France. Thank you for joining, and